بسم الله الرحمن الرحيم. أعزائي الطلبة، السلام عليكم. Dear medical students, welcome. I'm Dr. Khaled Darahim, Professor of Cardiovascular Medicine. In this lecture, we will discuss the ECG in a simplified approach. Actually, the learning outcome for this lecture will be on two main subjects. First is the ECG basics, how to interpret the normal ECG and evaluation of the ECG so that you can get a report from the ECG recordings. The second one will be arrhythmias, and a simplified approach being a medical. To understand this, we have to define what's meant by ECG. ECG actually is an electrocardiogram. An electrocardiogram, as we know, is a recording of the electric activity. And this electrical activity, in the ECG, we record it on a graphic paper. So we can see what is going on through the electricity of the heart. And to understand this subject, we have to know that there are two types of myocardial tissue. First, the ordinary myocardium, atrium and ventricle, which is responsible mainly for contraction. The other type is a specialized cardiac conduction system. As we see here in this graph, this is the SA node. Normally, this is the pacemaker of the heart, and there is AV node, and this is the His bundle, and this is the bundle branch, right and left. The left has posterior and anterior fascicles, and through this bundle branches and fascicles we have a network of Purkinje fibers which conduct the signal of depolarization to each portion of the ventricular myocardium. So the function of this myocardial specialized system actually is the conduction of electric impulse together with the ordinary myocardium. But we have this conduction system at different speeds. We have the speed is very slow at the AV node, and this is for the purpose of delaying the contraction to allow atrium to empty the blood to the ventricle. And then it is very fast, the conduction in the His and bundle branches and the Purkinje system, so that to allow the ventricles to contract simultaneously and at the same time. We should also notice that the atrium and ventricle are electrically separated, and normally the only way for conduction through the AV node. That's why the AV node has a very slow conduction, and the atrium cannot conduct through it because the fibrous tissue intervening between the atrium and ventricle. Another function of this specialized electrical conducting system is it also possesses what's called spontaneous depolarization or spontaneous firing, which enables these cells to function as a cardiac pacemaker. The inherent spontaneous rate of the sinus node ranges from 60 to 100, and this is the fastest depolarization rate in the conduction system. That's why it is the normal dominant pacemaker. The AV node can also fire spontaneously but at a slower rate. The bundle branches, Purkinje fiber, also can fire but at a very slow rate, and it will not be apparent unless the dominant pacemaker, which is SA node, stop to work for any reason. So when the SA node depolarizes at a fast rate, it suppresses other potential pacemakers. That's why the activity is normally recognized. This activity of the potential pacemaker only recognized when sinus node fell below this other pacemaker for different reasons or for any disease. But normally the normal pacemaker of the heart arises from the SA node. The Ecg waves and intervals, when we record, or it was first recorded, the Ecg or the electrical activity of the heart on a paper, we see different waves. We have first the P wave, and this P wave reflects the activation or depolarization of the atrium, both right and left. And this the P wave, and then followed by PR segment, as we see here, and this is isoelectrical segment. During this period the atrium repolarized, but normally we don't see this effect on the Ecg. And then we have the Qrs complex, as you see here, and this reflect post-ventricular depolarization. And because they are depolarized at the same time, so we have narrow complex, as we see in the normal Ecg. And then we have the flat isoelectric line, which is the ST segment, and then the T wave. T wave reflects ventricular repolarization. We have at the end a small wave, which is sometimes seen, sometimes not seen, and this debatable etiology may be late portion of ventricular repolarization, or sometimes called repolarization of Purkinje system. This is unknown mechanism. We have also the QT interval. This QT interval reflects both ventricular depolarization and repolarization. So also we have another interval, which is a PR interval, and this PR interval reflects the onset of atrial depolarization to the onset of ventricular depolarization. So it entitles the atrial activity plus the delay in the AV node until the impulse reaches the ventricle. So we have P wave, QRS, T, we have PR interval, PR segment, this is the ST segment, and this is the QT interval. As regard nomenclature, QRS, Q is the first negative deflection. Sometimes if it is large, we call it Q capital. If it is small, we term it Q small. The R wave, it's the first positive deflection of the QRS. The S wave is the second negative deflection. Each letter of the QRS can be written as small or capital according to the size. If it is small, it will be small. If it is large, it will be large. So the second thing of the basics of the Ecg, we have to know the paper itself and the leads. The paper, this is the Ecg paper. We have a standard calibration, which is the speed. It's 25 millimeter per second. That's say if you run by 5 large squares, it is 1 second. So each large square represent 0.2 second or 1/5 of a second. Each small square will be 40 millisecond or 0.04 of a second. The normal or standard calibration usually also, as regard the voltage, we have 10 millimeter equals 1 millivolt. So each small square will be 0.1 millivolt, and each two large square will be 1 millivolt. So this is a standard calibration we have to see, and that's why the Ecg papers are divided into small and large squares. The second important concept in the Ecg is the term of the Ecg leads. What we mean by Ecg leads? The Ecg lead means that the ECG or the electrode of the ECG which look at the heart from one different direction. So in Arabic we call it متجه, يعني how we look to the heart from which portion, in the vertical plane or on the horizontal plane. So we have 12 leads, 6 limb leads and 6 chest leads. They based on the fact that electric impulse which travel towards the electrodes, and I mean the electrodes, the positive electrode, produce an upright like this portion. The electric impulse travels to the electrode, so we have a dominant R wave. If it is away from the electrode, it will be mainly negative S wave. If it is perpendicular, it will be biphasic, R and then S. If it is oblique, so we have here small r and deep S. If it is oblique in this direction, we have large R and small s. So this is the idea of making different electrodes so that we can see the heart from different directions. As you see here, this is the limb leads. We have 6 limb leads. Imagine you are seeing the heart from the front. يعني المريض قصادك، واقف قصادك، راسه لفوق رجليه لتحت، فانت بتشوفه من كذا متجه. هو normally ventricular depolarization comes from 10 o'clock this way to 4 o'clock. So we have 6 leads arranged so that, as in this figure, at the 0 point we have lead 1, lead 2 at 60° positive, so towards the left leg, and lead 3 it is plus 120. And we have also the augmented limb leads, AVL, AVR, AVF. AVF exactly down 90 degrees, perpendicular to lead 1. Lead AVR minus 150, this is towards the right atrium, and lead AVL minus 30. So we are measuring the patient in front of us. This is the head, this is the legs. So we have 6 different leads looking at the heart from different direction in frontal plane. As you see here, because the main vector of the heart toward this 4 o'clock, so lead 2 is around 60 degree. So we have the largest R wave here in lead 2. Lead 1 also, and lead 3 and AVF, we have a smaller R because they are not in line with the actual vector of the heart. In lead AVR, this is minus 150. So as we see here, this is AVR, mainly negative direction. So the main vector of the heart towards this direction, this lead will show the largest R wave. This lead will be a smaller R wave, and this is a negative wave. So by this way we can look at the heart from different directions. Not important to know how these leads are constructed or invented, but the important issue is to know these leads looking at the heart from which direction. We have 6 limb leads looking at the heart in a vertical plane, so that imagine the patient is in front of you. This is in contrast to chest leads. Chest leads, as we see, arranged on the chest, and this is the thoracic cage, lead V1, V2. This is fourth intercostal space, right and left, and this is just parasternal, and this is the apex line, mid-clavicular line, face space. This is V4, and then V5 and V6. So these leads, chest leads, look at the heart in a horizontal plane. So imagine you are looking at the heart in a horizontal plane, so as if you are looking to the patient from the head. So this is a cross section of the patient. So lead V1, V2 looking at the right ventricle and septum, V3, V4 looking at the anterior wall, V5 and V6 looking to the lateral wall of the left ventricle. So we have 6 leads, chest leads looking to the heart in the horizontal plane. We have also 6 limb leads looking at the heart in a vertical plane from down laterally and to the right, left and right. So this is the idea of leads. Why we have 12 leads? To look at the heart from different planes, vertical and horizontal, and from different directions, so we can know which vector and which axis we can calculate. So this is basics of ECG, ECG leads, ECG paper, the origin of the waves, definition of the waves. So the next step will be we need to evaluate the ECG in a systematic way so that we can reach a diagnosis, and we should memorize it in a simplified way. There is a different items to be reviewed in the ECG. I'll try to simplify it in 2 main subjects. The first one will be the rate and rhythm. This is the first item. The second item will be A, B, C, D. A, axis, B, Qrs width or the bundle branch block. C is chamber enlargement, and this is through the QRS amplitude. And then D, data of ischemia, we revise Q wave, ST segment, T wave, and QT interval. So you will memorize in this way. This is a very simplified way, so that we have a complete report without forgetting anything. First thing, rate and rhythm, and second thing, ABCD, axis, QRS width, amplitude, and Q wave, ST segment, T wave, and QT interval, which is data of ischemia and other etiologies. First, we see the rate. Because the standard calibration at 25 mm per second, so as we said before, each large square means 0.2 second or 1/5 of a second. So calculation of the rate is very easy. We will calculate how many large square between the 2 R waves, as we see here, 1, 2, 3. So we divide 300 divided by 1, 2, 3, so the rate will be 100. If we have, for example, 4 large square between the 2 R wave, 300 divided by 4 will be 75. If we calculate the rate, especially at the higher rate, we can calculate it by the small squares. In this way, we, if for example in this we have almost here 15 small square, so we will divide 1500 by 15, it will be 100. So this is very easy. If we have, for example, the RR interval, as you see here, 4 square, we have rate 75. If it is 5 squares, it will be 60. 6 square will be 40, 50. And if it is 2 squares, it will be 150. So this is easy, but this is provided that the rate is regular. If we have a regular heart rate, we will count 6 seconds, that is 30 large squares, and then we calculate manually the number of R waves. And this is usually in patients with AF. So the first thing in the calculation of heart rate, to know this is regular or irregular. Irregular, get 6 seconds and count as R waves, multiply by 10. If it is regular, as in most cases you will see, so in this case you will divide 300 by the number of large squares. If, for example, in this patient we have 3 squares, so the rate is around 100. So this is as regard calculation of the rate. The second thing, we should know the normal sinus rhythm. What we mean by normal sinus rhythm? So what we mean by sinus is two things. First thing, the P wave is upright in lead 1 and lead 2. This is in the sinus rhythm. Another requirement is that each P wave to be followed by QRS or R wave, and with a normal constant PR interval. So if these two conditions occur, so we have a sinus rhythm. If the rate between 60 and 99, so this is normal sinus rhythm. Less than 60, it will be sinus bradycardia. More than 99, it will be sinus tachycardia. And usually the rate is regular. If it is irregular and sinus, this is maybe sinus arrhythmias, but this is in the normal sinus rhythm. Why we said normal? It is regular and rate between 60 and 99, let's say 3 to 5 large squares. Why we say sinus? Because P wave is upright in lead 2 and 1, and each P wave followed by a QRS with a normal PR interval, and this PR interval is constant in different ways. In a practical way, this is normal ECG, and this is normal sinus rhythm. Why we said normal sinus rhythm? First thing, the rate, as you see here, the rate is almost, as we see here. First, when we look to the rhythm, or to say normal sinus rhythm, we will calculate the rate and regularity, usually in rhythm strip, which is lead 2. So we will see here in this lead, almost we have 1, 2, 3, 4 large squares. So the rate here is around between 75 and 80. So this is normal rate and it is regular. So if it's sinus, we will say this is a normal sinus rhythm. Why it is sinus? We look to lead 1 and lead 2. We see here B wave is positive. B wave is positive. The other thing, each P wave followed by R wave. Each P wave followed by R wave. Each P wave followed by R wave. And this PR interval is normal and constant. Normal PR interval between 3 and 5 small squares. Let's say 120 to 200 milliseconds. So as we see here, it does not exceed 1 large square or 5 small squares. So this is normal P wave upright in 1 and 2, and also normal PR interval, which is constant, and each P wave is followed by R wave. So this is sinus rhythm. We look to the rate and regularity here, so this is normal sinus rhythm. So this is very easy. If you see sinus rhythm, why sinus rhythm? P wave upright in lead 1 and 2. Each P wave is followed by R wave with normal and constant PR interval. And also we have the rate is around here 75, and it is regular. So this is normal sinus rhythm. And actually this is normal ECG. So the first item of interpretation is rate and rhythm, and we have here normal sinus rhythm. The second item, which will be AP simple way, we will put lead 1 up as it is normally in the ECG, and lead EVF down. If this is both are upright, this is normal axis. If they are shaking hands, usually we shake hands by the right hand. So if this is negative and this is positive, they are shaking hands. So this is shaking with the right hand. So this is right axis deviation. If they are away from each other, so lead 1 is positive and lead EVF is negative. So this is left axis. There is a difference between left axis deviation and left axis without, sometimes called leftward axis, but left axis deviation is a little bit different. So we have to have lead EVF negative and also lead 2 is negative. So and this is another requirement for left axis deviation. We have to have lead 1 up and lead EVF and 2 is down. So just memorization, left axis deviation, they are away from each other. Right axis, they are shaking hands with the right hand, so lead 1 is negative and lead AVF is positive. If both are upright, this is normal axis. As regard the second item, which is B or bundle branch block, we have the Qrs duration. Normal Qrs duration from 60 to 100. If it reached 120, so this is bundle branch block. What mean by bundle branch block? The impulse travel through the AV node and then to the His bundle, and normally it conducts through the right and left bundle simultaneously. But if one bundle branch is blocked, so it will travel rapidly through the other bundle and slowly through the ventricular myocardium through the site of this obstruction. So it will take a long time. So when it takes a long time, this means the Qrs duration will be wide. So when we have normal PR interval and then wide QRS complex, let's say 3 small squares, 120 milliseconds or more, this is bundle branch block. Whether right or left, we can know it by the ECG. We see here in the ECG, and this is the normal narrow complex in the ECG. So this is normal conduction. This is normal QRS duration. When we have bundle branch block in the right bundle branch or left bundle branch, we know this through lead V1 and V6, and usually I add lead 1, which is the lateral lead, together with V6. I see the M pattern, this M pattern R, S and R dash. This M pattern is present on V1, which is the right-sided chest lead, so will be a right bundle branch block. If this M pattern is present in the V6 or lead 1, so this is a left side chest lead, so or left side lead, so this is M pattern in left side will be a left bundle branch block. We see here a clinical example. In regular, as we see here, regular interpretation, P wave upright, lead 1 and B2, lead 1 and lead 2, and then each P wave followed by R wave, and then so this is sinus rhythm, and we see here an R interval around 4 to 5 square, so rate is around from 60 to 75, so this is normal rate and it is regular, so this is normal sinus rhythm. Here we will apply the axis again. As we see here, lead 1 is positive, lead EVF is negative, so they are away from each other, so this is left axis, but to confirm to look to lead 2, if again negative, so we have left axis deviation. And then we'll see the Qrs duration. Qrs duration, as we see here, is actually 3 small square or 3.5 small square. So this is normal PR interval with wide QRS. So in this case, when we have normal PR interval and wide QRS, so we have a bundle branch block. We'll see where is the M-shaped pattern. We see this M-shaped or the large area in V6 here. This is M pattern and also in lead 1. So, and in lead V1 we will a deep S. So in this case, M shaped in V6 and lead 1, which is the left side. So this is left bundle branch block. The opposite in right bundle branch, we will see M shaped pattern here and deep S in this way, and also in lead 1. So we have the M pattern here, V6 and lead 1, so this is left bundle branch block. In this example, again, this is sinus rhythm. Rate is around 100 or a little bit less than 100. So this is normal sinus rhythm, and this axis actually is normal, is up, and this is up. And then second thing with Qrs duration, we see here Qrs duration here is wide, around 3 mm, and this is M-shaped pattern, and it's more obvious here, of course. So it is M-shape pattern in the right chest lead V1, so this is right bundle branch shock. In lead V6, we see here an S wave, which may be not apparent, but in lead 1 it is much apparent, deep S here, deep and wide S. But to be easier, M-shape pattern here in V1, V2, so this is right bundle branch shock. The third item is the chamber enlargement. This is ventricular chamber enlargement. This is as a QRS amplitude. And also we will see in the chamber enlargement also the right and left atrial enlargement. The right and left atrial enlargement, we know it from the, of course, is a P wave. The normal P wave should be less than 2.5 in height and width less than 3 millimeters. So in right atrial enlargement, as we see here, we have tall and peaked P wave. What I mean by tall, it is 2.5 or more millimeter. As you see here, more than 2 millimeters, so this is right atrial enlargement. And also the left atrial enlargement, we see here, we have different causes, of course, but how can we diagnose it? By duration. If reached 3 millimeters square by width, that is 0.12 second, so this is left atrial enlargement. Another way is to look to lead V1. If we have a wide terminal trough or terminal deflection more than 1 millimeter, so this is left atrial enlargement. So atrial enlargement, we usually see it in lead 2 and also in V1. If this is wide, so we have left atrial enlargement. If it is tall, we have right atrial enlargement. Both enlargement can occur, yes. We will have tall and wide. Tall 0.25 millifolds, let's say 2.5 small square in height and 3 small squares in width. So this is easy for diagnosis. As regard ventricular enlargement, we know this is a normal QRS amplitude. Left ventricular enlargement, usually exaggeration of the normal. So we have tall R in V6 and deep S in V1 and V2. There is Sokolow line index, which is you get the sum of the S wave depths in V1 plus V2, or V2 plus the largest of V5 or V6. And then if this sum more than 35 millimeter, let's say 7 largest square, so this is left ventricular enlargement. And that's mean you will see V1 and V2, this is the largest one of them, and then you see how many squares. This is, for example, 5 squares, and this is V5 and V6. You will get which one is the large. For example, V5 largest one is 5 squares, so 5 and 5 is 10 squares. 10 squares, this means 50 millimeter. So if it is more than 35 millimeter, this is LVH. Another way is to look for height in AVL alone. If it is more than 11 millimeters, so this is again LVH. As regard right ventricular enlargement, this will be a reversal of the normal. So we'll have deep S here in V6, and lead V1 will have either monophasic R or R more than S. So there is also a prerequisite that to have right axis deviation. So in RVH we have 2 criteria. First one is tall R in V1. This is the normal. As you see here, there is mainly small r and deep S. And RVH is monophasic R or even QR or RS, but the R is larger than the S. The other requisite is you have right axis deviation. What we mean by right axis deviation, as we said before, let's say deep S and lead 1 and tall R and lead EVF. So by this way we can diagnose right ventricular hypertrophy. This is an example of right ventricular hypertrophy. As we see here, again is a regular interpretation. This is sinus rhythm V1, V2 atrium are positive. We have here monophasic R and lead V1 and a little somewhat deep S in the lateral leads. So this signifies right ventricular enlargement. But because there are other etiologies for tall R in V1, we have to add this criteria, which is right axis deviation. This is lead 1 and this is AVF down. So we will see here this is positive and this is negative. So they are shaking hands with the right hand, so this is right axis deviation. So when we have tall R in V1 or R more than S in V1 plus right axis, this is right ventricular enlargement. And this, as we see here, this is LVH. This is again sinus rhythm, but this is deep S in V2 and tall R in V5 and V6. We 1, 2, 3, 4, 5, 6, 7, and this is 1, 2, 3, 4, 5, 6. So we have 13 large square, let's say 65 small square, and we will diagnose LVH if it is more than 35. There is other also criteria like tall R in AVL. Here, as you see here, more than 11 small squares, it is almost here 13, so this is another index for LVH. We have different or many actually scores, but this is the most famous of them. So we have this is the C, which is chamber enlargement or Qrs amplitude. The last item in my scheme is the data of scheme is let's say Q wave, ST segment, T wave, and Acuity interval. As you see here, the pathological Q wave, we discuss of course the R wave in the chamber enlargement, the Qrs amplitude, the width, and here we'll define each wave. We have here pathological Q waves. We have normal actually Q wave in lead AVR. This is normal. And sometimes we have isolated large Q wave in V1 and lead 3. And sometimes also we have very small Q waves in the lateral leads, V5, V6, lead 1 and AVL. But when we have a pathological Q wave, and this is sign of myocardial infarction, whether old or acute, this is a Q wave which is 1 millimeter wide or more, or deep, let's say more than 1/4 of the subsequent R wave. When you have this, so this is pathological Q wave and signifies presence of myocardial infarction. So here we will have the ST segment. ST segment, the normal ST segment as we see before is an isoelectric, and the junction of ST of the QRS complex and the ST segment, this is the J point. So when you have elevation or depression of this J point by 1 millimeter or more, this is abnormal. So we can have small or mild depression or elevation, but this J point or the junction between the ST segment and QRS complex is 1 millimeter, so this is abnormal. And of course we have causes for ST depression and ST elevation. ST depression occurred in myocardial ischemia, especially in acute coronary syndromes or even in stable angina during exercise testing. Sometimes occur with ventricular hypertrophy, with bundle branch block, and with digoxin toxicity. However, ST segment elevation or the J point elevation, this occur in myocardial and represent myocardial injury, and this is the hallmark of ST segment elevation myocardial infarction or STEMI. This is a very serious diagnosis, and we diagnose it if you have this ST segment elevation in 2 contiguous leads. Another etiologies of ST segment elevation, including LV aneurysm, left bundle branch block, pericarditis, benign depolarization. But in ST elevation, as you see here, it is usually associated with pathological Q waves. And we said that two contiguous leads, and distribution of the leads will define the site of infarction. If we have leads, chest leads V1 to V4, this is anteroseptal. This is V1 to V6, anterior, extensive anterior. Lead 1 and AVL lateral, or sometimes said high lateral ST elevation MI or STEMI. And the inferior leads lead to 3VF. If we have elevations, this is inferior STEMI. And the shape of this ST segment elevation actually is different, but all share this J point. This is the junction of QRS and ST segment. As you see here, it should be isoelectric here, but here it is elevated almost 1, 2, and 3 small squares, and it can be flat. Usually it is convex, as you see here, but it has different shapes. All this signifies ST elevation MI, and all share that we have pathological Q together with this ST segment elevation. So when you see this is a STEMI, and according to the distribution of leads, we will diagnose the case. As in this case, actually, this is anteroseptal ST elevation MI. As you see here, this patient coming very early with almost very small Qs, this is very early and hyperacute T wave, but we have here ST elevation V1, V2, V3, and V4. So this is the J point elevated here around 2 millimeter, here around 6 millimeter, here around 5 millimeter. So this is elevation V1 to V4. This is acute anteroseptal MI or myocardial infarction. In this example, we have ST segment elevation here. Of course, this is sinus rhythm, as we said before, and normal axis, normal Qrs duration, no chamber enlargement, and normal axis. And we see here there is pathological Q wave here, as it is almost more than 1/4 of the R, and this is ST segment elevation here around 1 millimeter, 1.5 millimeter here, almost 1.5 millimeter. So we have ST segment elevation MI in D2, 3, and AVF. So this is inferior ST segment elevation myocardial infarction. As regard T wave, normally the T wave is asymmetric. What do you mean by asymmetric? It's slowly uprising, and descending limb is more steep. It usually less than 2/3 of the corresponding R wave, and it is in the same direction. Let's say negative in AVR and positive in lead 2 and V4 to V6. Abnormalities of T wave, if we have symmetric T wave, and this is Eukaryotic ischemia. If you have tall peaked T wave, this is hyperkalemia. And if it is inverted or biphasic, this is have many reasons, including ischemia, ventricular hypertrophy, bundle branch block, digoxin, electrolyte disturbance, a lot of causes. The Acuity Interval, actually duration between 0.3 to 0.55, and actually this depends on the heart rate. It shortens with rapid heart rate and it lengthens with slower heart rate. That's why the proper way to identify it is the corrected Q wave. We corrected by different formulas, but an approximate estimation, if you have the Acuity Interval duration more than the interval between the adjacent R waves, so this is abnormal. As you see here, there's different formulas to correct the R wave Acuity Interval. It should be 0.45. This is the normal thing. If exceeding this is large, and usually we have a lot of causes for Acuity Interval prolongation, and this is can predispose to ventricular arrhythmias. Causes include congenital ischemia, electrolyte disturbance like hypokalemia, and many drugs like erythromycin. So in this way we should be cautious, because this can predispose to ventricular arrhythmias. So by this way we completed actually the full interpretation of the ECG, and this will conclude the first portion of our lecture. We should remember this scientist, and this is a Dutch doctor, which is Einthoven. This is in 1903. Is the one who invented the electrocardiogram. And as you see here, this is bulky, a machine, and you should put your right hand, left hand in water, and also your left leg in a large basin of water. And this, you are sitting here, and by the end of this machine you have only 3 leads, lead 1, 2 and 3, with the bipolar limb leads invented by Einthoven. And this is in comparison to the recent ECG machine, which is digital and touch screen, and you can have automatic computer-based interpretation. So this the modern ECG machine versus, and of course we should remember that Einthoven won the Nobel Prize in this medicine in 1924. And actually, after the invention of the ECG, the term cardiologist evolved, because the definition of cardiologist at such time, which is a physician, internist, which is expert in ECG. So this is the definition of cardiologist at such time, and still actually it is mandatory for cardiologists to know the ECG in details. But because the ECG is widely available and is inexpensive and very effective, so I think every physician, including primary health physician, and even that's why we are teaching ECG for medical students, to know the broad diagnosis of, and as we see, and as we will see in our example, this will be life-saving, and we don't have time to refer to a cardiologist to interpret the ECG. So each doctor should have a basic knowledge of the ECG. And this will bring us to the second subject of our lecture, which is arrhythmias. Arrhythmias, which is the disturbance of cardiac rhythm. There is different types of arrhythmias. We will have a brief resume in these types. First thing is premature atrial contraction, which is atrial contraction coming before the next P wave, so it comes premature before the next P waves from the sinus node fires. So we will have this different P wave, because coming from the atrium, not from SA node, so it will have a different morphology, and it's coming early. Apart from the normal, this is the normal sinus rhythm. So if one come earlier than this P wave from the SA node, so the term premature atrial contraction, or premature atrial depolarization, or atrial extrasystole. To diagnose it, we have to have a P wave, which is a little bit different from the sinus rate, and it is coming early, and the QRS should be narrow and similar to that of the sinus rhythm. So this is premature atrial contraction, and usually this is asymptomatic, and actually this is, if it is very few, is a benign condition. The second thing is premature ventricular contraction. So we have here ectopic focus from the ventricle, which discharges before the next sinus beat, so it is an early. So we don't see a P wave here before this wave, and this beat is very wide. So let's say more than 3 small squares. So it's coming from the ventricle. So we have wide bizarre QRS complex, absence of P wave. This signifies BVCs. And there is usually a compensatory pause, as you see here, because the next P wave will come here. It will not fire because the ventricle is refractory, so the SA node will not be reset. So this is the second P wave. So we have, as you see here, compensatory pause. And if you calculate the RR interval between here and here, it will be double the one from here and here. So this is what's termed compensatory pause. And usually, because the ventricular contraction here is not effective, so the patient will feel it as a skipped heartbeat. This one is usually symptomatic. Here no pulse, and then here will be a strong pulse. So either the patient will feel a skipped beat or a strong beat here. So usually this is symptomatic. So it is easy to diagnose. This is BVCs. The second item we'll review is the atrial fibrillation. And atrial fibrillation occurs when there is multiple ectopic reentrant focuses in the atrium, which causing multiple firing of the atrium by a very rapid rate, usually exceeding 350 beats per minute. So not all will be conducted, and the AV node will protect the heart and conduct some of them. So we will have irregular rate, as you see here, because this is irregular multiple ectopic foci, and we will have absent of the P waves, no P waves, and either a flat line or irregular waves. This can be fine or coarse. We can have fine fibrillation or coarse fibrillation, and usually this fine or coarse fibrillation are seen in lead V1. But the criteria for diagnosis of AF is two things. We have irregular rhythm and absent P waves and replaced by fibrillatory waves. The importance of this arrhythmia is it is very common arrhythmia. The most common chronic arrhythmia is atrial fibrillation, and usually the atrium stop contracting, and then the blood pool in the atrium, usually in the atrial appendage, and can stagnate and can form intracavitary thrombi or clots, and this can embolize from the left atrial appendage to cause a stroke. So this is very dangerous arrhythmia. It can cause stroke, which is the most common cause of disability in adult population. And the fortunate thing is that this incidence of stroke can markedly be reduced by giving anticoagulation or anticoagulant drugs. So the importance of this arrhythmia, when you see it, you have to classify the thromboembolic risk. Usually it is high in elderly population, and in this case it is mandatory to give them anticoagulation. And this anticoagulation is very important in reducing the incidence of stroke. We know that at least large portion of embolic stroke can be prevented by giving anticoagulation for this patient with atrial fibrillation. To the ventricular tachycardia, which again tachycardia, as you see here, the interval is around 2 large squares that stay at 150, but it is regular again, but the QRS complex is wide. So it is originating from the ventricle, so it is not atrial or junctional, it is ventricular tachycardia. If you have narrow complex, this is supraventricular tachycardia. The danger of this ventricular tachycardia, it can degenerate into ventricular fibrillation, and this is of course you will not see it in 12 lead ECG. This is monitored because this is the most common cause of cardiac arrest. So and the treatment in this condition is to give defibrillation, direct current defibrillation or DC shock as soon as possible, so that you can increase the likelihood of survival. As you see here, this is ventricular tachycardia generate into ventricular fibrillation. This is usually one form of cardiac arrest, the most common form, and usually it responds to DC shock. So this is very important to recognize. As regards the disturbance of the cardiac rhythm, we have tachycardias, we have also bradycardias. We have what's called AV block, or block usually occur in the level of the AV node. The first degree heart block is the AV node become deceased, so it is prolonged the conduction. So as we see, the PR interval is lengthened more than 0.2 seconds. So if we have the PR interval more than 5 small squares, so this is first degree heart block. And usually does not require a specific treatment. The second degree heart block, that say not all cardiac impulses are conducted to the ventricle. So we have two types. The first type is Mobitz type 1. This is second degree type 1, which is called Winkbach. We have here progressive lengthening of PR until 1 will not be conducted. So we have what's called group beating, yani every 4 P waves, 3 are conducted. So this is the first type, which is progressive prolongation of the PR interval until 1 is not conducted. This is second degree type 1, Mobitz type 1, which is Winkbach. The type 2, which is we have every 3 or 2 beats, either 2-1, 2-1 or 3-1, 1 is conducted. We see here 1 conducted, 1 not conducted, 1 conducted, 1 not conducted. So in this case, we have 2-1 block. We should recognize that here the PR interval is rather constant. As you see here, 1 here constant and then 1 dropped. 1 constant, 1 dropped. 1 constant, 1 dropped. Sometimes you have 3-1 block. Yani every third beat 1 is blocked. But the diagnostic thing is the PR interval is constant. Third degree AV block, we have complete heart block. The atrium fires alone and the ventricle fires alone because the AV node is completely obstructed. So there is no conduction between the atrium and ventricle. So the atrium usually conduct, you have P wave here, P wave here, P wave here, P wave here, P wave here. And this PR, P or PP interval is constant. For example, here at a rate of 100. And then the ventricle escapes, usually in the Hesper-Kenji escape. So we have also QRS interval are constant. So by this way we will have the ventricular rate at rate of 30, for example, or 35, and then PP or the atrial rate by rate of 100. So complete dissociation. To differentiate it from second degree, we see here the PR interval here is very variable. So as you see here, very variable, very variable. And this QRS interval is variable. So and usually QRS here is wide. So we can differentiate it from the second degree heart block. The Mobitz type 2 usually have fixed PR interval. In Mobitz type 1, the Winkbach, as we see before, there is group beating. Yani 3 beats are regular and then 1 drop. 3 are regular and 1 is drop. If it's 4-3, sometimes 3-2. Yani every 2 beats 1 drop. So this is progressive PR prolongation, and 1 is not conducted. But here there is complete dissociation. So this is the third degree AV block, complete heart block, and usually this requires a pacemaker or insertion of pacemaker. So this is a resume of evaluation of the ECG, the rate and rhythm. This is the first item. Second item is the QRS axis. This is A, and then B, bundle branch block or QRS width, and then C with the chamber hypertrophy, QRS amplitude together with the P wave assessment. The D, which is the data of ischemia, includes the Q wave, ST segment, T wave, QT interval. And this is to just a refreshment for you, a few test slides. This is a 20-year-old male coming to the ER. We see here the ECG. We evaluated systemically, P wave positive in lead 1 and lead 2. So this is sinus. Rate is around 80 or 75, around 4 large squares. And it is in lead 2 regular, as you see here. This is rhythm trip. So it is regular. So this is normal sinus rhythm. And then we'll see A axis, lead 1, lead EVF, both are positive. So this is normal axis. And then we'll see Qrs duration less than 3 small squares, so no bundle branch block. And then we'll see chamber hypertrophy, Qrs amplitude. As you see here, there is no dominant R nor RVH. Here, not tall V5, V6 or V2 and V1. So the sum less than 7 square. So this is not left ventricular hypertrophy. We'll see also P wave here is not tall and not wide. So there is no chamber enlargement. We'll see data of ischemia, no pathological Q waves, isoelectric ST segment all through. T wave is upright and lead 2 and lateral chest lead. So this is normal. So no, QT interval here, as you see, this is onset from Q to the T, and if you can concentrate, this is RR interval. The QT interval is less than the half, so this is normal ECG. We can say it with confidence, and as you see here, it is simple to say this is normal ECG if you have this algorithm we just said. This is a question. We have to identify the following rhythm. Is this atrial fibrillation at 90 per minute, or Wink-Bach, or sinus rhythm, or sinus arrhythmias? As we see here, we have to calculate the rate and rhythm first, and also assess the P and P wave and PR interval. First thing, we don't have here a clear P wave. This is again fibrillatory wave. You cannot say this P wave because this is different, this is different, this is different. So no P wave in place, and hence consequently there is no PR interval, so fibrillatory waves here. And this is, as you see here, irregular rhythm. So when we have irregularity and absence of P wave, this is atrial fibrillation. As regards the rate, this is almost 6 seconds. We count 1, 2, 3, 4, 5, 6, 7, 8, 9, multiply by 10, so it's 90. So this is atrial fibrillation at 90 beats per minute. It is easy. We have here coarse atrial fibrillation. Don't be missed by this coarse fibrillation. You said that this is P wave. No, this is not P wave. As you see, it is coarse fibrillation. All are different. So this is atrial fibrillation. Again, in this example, as you see here, assessment. First thing we will see the rate and rhythm. To calculate the rate, we have to get whether this is regular or regular. As you see here, we have here irregularity, and this lead to we cannot say there is no P wave or undifferent. So this is not P wave. This is fibrillatory wave. So we have irregularity and no P waves. As you see here, no P waves, no P waves. This is fibrillatory waves, and usually coarse or fine seen in V1. As you see here, this is coarse fibrillation. It's very easy here. So this is atrial fibrillation. We get 6 seconds, 2, 3, 4, 5, 6. So calculate here 1, 2, 3, 4, 5, 6, 7, 8, 9. So this is atrial fibrillation at a rate of 90. Complete the report. Yes, we will complete it. A axis, as you see here, axis is normal. Qrs duration normal, no bundle branch block. Again, no chamber enlargement. We cannot diagnose atrial enlargement because there is no P wave here. Data of ischemia, there is no Q waves. ST segment isoelectric. T wave upright all through. QT interval, as you see here, is normal. This is RR interval, and this is the less than half. And if you calculate it even here, from here to here, almost 0.4. So this is normal QT interval. So our report is atrial fibrillation at a rate of 90 beats per minute. This is easy. Here, this is chest leads only, with a man presented with chest pain for 2 hours. He's old one, 56-year-old male. As you see here, because they are not giving us the limb leads, we will not calculate the rate and the rhythm, and also the axis or bundle branch block. So we'll concentrate on data of ischemia here. As we see here, there is pathological Q waves here, V2, V3, V4, V5, V6, and there is ST segment elevation as you see here from V2 to V6. So this is acute anterior ST elevation MI. This is also, as you see here, normal sinus rhythm here, P wave upright here and here. Rate is regular and around, as you see here, around 60 per second. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Yani almost bradycardia also, because it is exceeding 6 seconds. So it's sinus bradycardia. And as you see here, the axis is normal. No bundle branch block, Qrs duration is normal. No chamber enlargement, as you see here. No atrial also enlargement. As regard data of ischemia, we have Q wave here, lead 3. And then we have clear ST segment elevation around 2 mm, lead 2, 3, and AVF. So this is inferior ST segment elevation MI. Acuity interval is normal, T wave is upright. So this is acute ST segment elevation anterior MI. There is also elevation V5 and V6, so this is infralateral ST segment elevation MI. So these are few examples. I'll stress again the importance of ECG for the medical students, because they are the future doctors, and not all of them will be cardiologists, but there is several diagnoses which time is very important. As you see that atrial fibrillation in the elderly, this is precursor for stroke, which is a disability, major cause of disability in elderly population. So if you diagnose this atrial fibrillation, you will refer it to a cardiologist to prescribe oral anticoagulation, and you will save this patient from a future stroke. The other thing is diagnosis of ST elevation MI, because treatment should be in the first hours, because as you see, the revascularization usually the standard of care is primary angioplasty, yani catheter based removal of the thrombus or disintegration of the thrombus. And as we know, time is muscle. The more you are delayed, the more the patient will have myocardial infarction and eventually can lead to heart failure and death. So when you diagnose the case, you should refer him immediately to the nearest hospital when you have this ST segment elevation MI. You don't have time to refer it to a more specialized care. So for interpretation of ECG, when you diagnose it, just refer him to the ER immediately, to the nearest hospital. So in this case, the diagnosis of, or the ECG diagnosis for the primary healthcare provider is very important. That's why the medical student should concentrate on this ECG basic diagnosis as we have in this lecture. And I think this is very important for the health of the patients. Thank you and for your listening. And if you have any questions, I'm glad to have it answered. I left my official mail in this slides. And I hope this lecture will have an impact on your future practice, not only on the exam. Thank you. Assalamu alaikum wa rahmatullah.